Greetings and welcome to AWHONN Insights, the home for candid nursing conversations. Today, we're discussing the importance of anesthesia providers in the care of the high-risk OB patient. Our distinguished guests are Norman Roberts, a certified registered nurse anesthetist, and Dr. Shafanya Turner, a board-certified anesthesiologist with over 20 years of experience in medicine and founder of Caring for Us Core. I'm your host, Bria Anopise, and I'm joined by Lakisa Ballard, a clinical nurse education specialist in obstetrics and member of the Maternal Mortality Review Team of Maryland. Lakisa, the podcast is all yours.
Hello, everybody. We're going to go ahead and get started with our first question. So, Shafanya, how does the role of the anesthesiologist and the OBGYN differ?
Well, I think everyone's pretty familiar with, an OB. An OB is the person who is in charge of, delivering the baby. I think that's what overall people believe or know. But there's another role that the OB plays, and that's also making sure that the mother is safe and taken care of. And that's probably the most important role. We always say, a healthy mom is more likely to produce a healthy baby or deliver us a healthy baby. So that's the role of the OB to keep mom safe so we can have a safe delivery. But then after that, there's other care that takes place. So after the delivery, mom goes to recovery, mom goes to, her postpartum visits and things like that. So the role of the OB continues on and on and on after the delivery. The difference with the anesthesiologist is that my role or our role is very acute. So it's during that moment of, having the baby, that process. And sometimes it's labor. So there's, epidurals involved and things like that. Sometimes it's a C-section. And there's other procedures that happen along in there. But the role of the anesthesiologist is to keep the mother safe and comfortable during whatever procedure she has presented for. So if it's labor, people, think of us as the one who sticks the needle in their back for the pain medicine. If it's a C-section, there could be any number of ways that we take care of the mom there. But our role is to make sure that I always tell patients that you're safe, number one, and comfortable, number two. They come really close together, but sometimes you might be a little mad at me. But if you and your baby are safe, I'm okay with you being a little mad at me. So that's kind of the difference.
Yes, safety is definitely number one. Absolutely. So, how important is the role of the anesthesiologist provider in high-risk OB situations? We know that happens pretty often as our um, community high-risk patient population grows. So how does that role um, serve as being very important with our patients?
Well, in high risk situations, um, the risk of badness happening just is a little higher. So that's high risk. Your risk is higher than someone else. So delivering a baby, I think because it's so ubiquitous and it's just part of, human history, I think people think it's something that's just natural and very, very easy to do. And it is natural. And in some cases it's very easy. But if you look back at the data and, just the story, the tradition of mankind, having a baby is a dangerous, scary moment. Um, and so, you have not only this life coming into the world, but this huge change in the mom physiologically that happens in a very short period of time. So, put all that with a high risk situation, and high risk could be any number of things. So we have moms that are having babies a little bit older now, and the longer you live, the more likely you are to acquire some other conditions, whether it's diabetes or chronic pain. We have a larger population right now. So, that complicates things, whether it's, me trying to put an epidural in a patient that's a little larger to, can the baby fit through out of the birth canal because of a larger mom, bigger babies because of diabetes. So the role of the anesthesiologist is we're kind of like crime scene investigators. Like I want to go in, I need to get all the information. I need to know. It's interesting, and I'll let Norman speak on this, like who the OB is that day is actually very, very important in how I navigate and move for the day. So, you know, To be honest, there are some people that I'm much more comfortable with than others. There are people who have more, more skills. There are people who have, you know, more patience, and sometimes more patience isn't a good thing. Like, I need you to make this happen quickly. So the high risk patient and anesthesia, they go hand in hand. Now, I think, it used to be kind of they were this special group of patients or whatever, but we're seeing more and more that high risk patients are probably becoming more of the norm, especially depending on the facility that you go into. Because if a mom is sicker, if a baby is sicker, then they're gonna, shunt them to another facility that can handle, whatever may come. So there's some facilities where mostly what they do are high risk patients. But Norma, what are your thoughts on it?
I feel like it's super important. And just to piggyback on what you said a little bit, it is very important who the actual OB doctor is that is caring for the patient. And just like Dr. Turner alluded to, that's gonna kind of dictate the path that you take and the arsenal of things that you're gonna bring with you when you do have to intervene. Is it a surgeon that if we're in a crash C-section, does he always lose an overt amount of blood more than this particular surgeon who does not? So, very, very important to maintain communication with the anesthesia providers especially throughout the high risk OP experience. I recently practiced at a facility and they do a very large number of deliveries per year, um, more than in they're at the top of the list in the state. Um, so they had a number of different physicians there, and sometimes when you're the anesthesia provider and you're coming in for your shift, you kind of want to know that first, right? So that you know the state of the patients that are currently laboring and on the floor, and kind of like who's at lunch right now, not really, I don't want to say ignoring the patient, but not being as vigilant as they could in the care of the patient. So maybe that's a patient I want to round on, a little earlier so that I can get the entire story. Let me go back in time and look at this patient's chart to see. I see this decel right now, but have they been doing that? Like, has it been communicated to the anesthesia team that these decelerations have been happening? Is the patient comfortable? Does she have an epidural? Is the epidural working? For some patients, even though they have an epidural, I've noticed, I'm sure Dr. Turner has seen, like, um, there's a level of local anesthetic resistance in some patients. So, like patients that have to get like multiple shots when they're at the dentist to get dental work done. There's a very small percentage of patients who don't respond the way that you would theoretically anticipate them to respond. So, to get back to the initial root of the question, very, very important, the anesthesia provider's role and knowing um, the history of the patient, right? Because a lot of times when you're coming in as the anesthesia provider, you're getting handoff from another anesthesia provider. It's not in all situations a nursing to nursing sort of uh, report off. So my anesthesia provider they may report off to me, oh, patient's fine, she has an epidural, she's comfortable. Or if I go and talk to the actual nurse for the patient, yeah, she has an epidural. It's starting to wear off. This is her most recent exam. She's not, complete yet. It's a more of a comprehensive, holistic review of the patient. And don't forget to go to the patient's chart to see exactly what's been going on, especially not in the entire stay of the patient, but definitely within that last shift, that last 12-hour shift. Very, very important to know. Um, Not all providers, and I'll just use that word as a blanket term encompassing everyone, um, document things the way they should be documented and or in the time that they should be documented in. So some very recent occurrences um, that you need to be made aware of, it's very possible that it has yet to even be documented. So that one-to-one communication is super, super, super important.
Thank you so much for mentioning that. As nurses, especially our nurses who work primarily in labor and delivery, it's very important for us to make sure we're in constant communication with anesthesia, with updates, even when people who are coming through triage, who may have a very significant history with a CRETA spectrum or anything that may potentially give them increased complications and what may need anesthesia. So that is very important. So the real-time documentation may not be afforded at that moment. However, we always can make a phone call, right? And and call and have a huddle. So those things will help to limit our gaps. Thank you for that. So moving on in, this would be a good segue. How do you, as anesthesia providers, arm clinicians with tools to not panic in emergencies? And as we're doing these simulation trainings in hospital systems and things like that, but what are some things that you do to arm our clinicians, nurses, and other providers with tools not to panic in emergencies?
Well, one of the things I'd make sure that everyone understands is that if I'm like, especially at night, if I'm covering the entire hospital, right? So there's an operating room downstairs, there's an emergency room, there could be airway emergencies and things. And I see that it's getting OB is getting busy, or I know something is going to come to the OR that's going to kind of divide my time. The first thing I do is I inform everybody like, okay, this is where I'm going to be needed tonight, right? So I need to triage um not only my communications, but do I need to call somebody else in, that kind of thing, to help support me. So you're letting everybody know, like, hey, it's just me, or this patient downstairs is bleeding out a lot, and I'm going to need to be down there helping out with that. So that's the first thing, is just my availability and resources. The other thing that we didn't discuss when we first talked about this, but right now there's shortages everywhere on um, medications, on epidural trays and needles and things like that. And that, so patients don't care. If they want an epidural, they need to be cared for. They don't care that you're short on stuff. But I need to, make sure that my colleagues know that whatever it is that we're running low out of, or the pharmacy, maybe they don't have any more bags of the medication that we hook up to the epidural infusion pumps. And they're making some more, but it's going to take me it's going to take them a few minutes or a few hours. So I just think, and kind of going to what I do, which is health literacy, like having the most information I can not only have it for myself but other people, I think is the first thing. And then I think, I'm gonna say it because I think it's true, and I think Norma will believe me. Like, we're kind of consummate pessimists. Anesthesia providers, we are always planning for the worst. We want the best for sure, but we're planning for the worst because when those moments happen, we have no time to, kind of strategize. So my plan is, if this happens, we're going to do this. If this happens, we're going to do this. So an easy example is the size of the IV. So when a woman has a baby, if she has it naturally, vaginally, and her uterus clamps down, she's going to naturally bleed out 3, 4, 500 cc, depending on which literature you use. So bleeding out a half a liter um, of blood really quickly can, shift your hemodynamic, blood pressure, heart rate, that kind of thing. Well, now you put high risk on it. She's had a whole bunch of babies, or it's a really big baby, or she's been, pounded with Pitocin for a bunch of hours. And so her uterus may not clamp down as quickly, so she's going to bleed out more. So for me, put a big IV in there so that we can rescue quickly, whether it's with fluid or with blood. If there's a patient that we think is going to be an airway issue, whether it's her size or she's had some, procedures on her neck. Like I said, we have a lot of older patients coming in now, older as in older than like 25. It's crazy. Because once you're over 35, you're considered an elderly, an elderly pregnant woman. So, we have patients who maybe we're worried about their airways. So I'm going to tell the OB team, like, this patient doesn't need to go back for crash anything, where I'm going to have to put her to sleep without, having some help around. So again, this is what I'm thinking. This is what I'm concerned about. Those are the tools for me. It's always information.
I feel, especially directly one-on-one with the nurses on the labor and delivery unit, to get them to not panic or freak out in any situation. I've never been a fan of the freak out. I think sometimes it's like a reflex almost. Some people, thrive off of that adrenaline rush, but always, or not always, but you're more likely to make a mistake when you panic and freak out. So I just tell everyone that I'm working with, like, hey, just to take some of that stress and anxiety, or um, that uneasiness away from it, call me sooner than later. You know, if you see even the most subtle nuance in your patient and it's a change, call anesthesia so that you're not behind the eight ball. So that would be number one. Um, and remember that we're there to support you. The patient is always first, but we're also there to support the staff, because all of us want the same outcome for both mother and the baby, right? So the freak out never is a good idea. Number two, always remember, you've made it this far. So there's a national board that says that you are ready to do this, to walk in this field. So bring it down to the basics and remember your nursing assessment. I always go back to, I don't care how far I go in nursing. That nursing assessment is just, you can utilize that in every single situation, and doctors can utilize that as well. Remember your priorities, your ABCs, your airway, your breathing, and your circulation. Just bring it back to, don't perceive that moment as, oh my God, this mother, she's gonna die, and the baby, and she's bleeding, and she's da da da, and her blood pressure to go. Just bring it back down. Okay, airway A. Does she have an airway? Okay, she's screaming. She has an airway. B, well, hopefully not screaming, but ventilating, we'll say. Um, Breathing, good. She's ventilating. You can see that she's breathing. She has an oxygen saturation level that's acceptable. Great. Circulation, is she bleeding? Does she have a blood pressure? Is it an acceptable blood pressure? How is that going to translate into blood delivery to the fetus? So there's very simple steps, even in an emergency, and it's always the same steps. So don't, while each patient is independent of the patient you took care of prior to, remember that we all built the same way, you know, with small, very degrees of variation. But we all have one heart, we all have two lungs, circulatory system, nervous system, um, body habit is obviously is different, medical history is obviously different, but in the grand scheme, lots of things are the same. So you had a patient bleed out on a Tuesday. Oh, now your patient's bleeding out on a Friday. You're probably going to do a lot of the same things. So try not to freak out. If there's something that you could have questions, definitely ask questions sooner than later. Not that you can't ask questions in the middle of an emergency, but if you are uneasy about something, or you don't really know much about a particular diagnosis, like, oh my God, Norman, they assigned this patient with reverse flow. Like, I don't know what that is. Like, can you tell me? Come to anesthesia if you don't want to Google it. Most anesthesia providers love to educate, because we want you to know the information so that we don't have to know it all when we get there. But I think in those situations, if they just remember that, um, you know, you have to be secure, not only in your own specific personal knowledge that you have, but know that you have a multitude of resources to go and acquire the information and the knowledge that you don't have. And I think it takes some of that angst and some of that, like, oh my God, dread doom feeling away.
Both of you all said some very key factors that I want to point out. So, Dr. Turner mentioned awareness of what's happening even in labor and delivery versus what may be happening in the ED, the main OR, whatever part of the hospital, if she is, or he or she is in charge of leading anesthesia that day, and notifying the obstetrical team. So I think that's very important that you amplify. Thank you for saying that. And also knowing what may be coming down the pipeline. And Norman, one of the things that you said I want to amplify is for the nursing colleagues to remember to trust in their training, and making sure that we understand that anesthesia is available. So we have a question, we have concerns for us to be able to articulate that and ask for bedside evaluation. If it's a question, there's no need to Google. We have the experts and very intelligent anesthesiologists in our midst. So we need to be sure to make sure that we build those relationships to when we do have questions or things are going awry, that we're able to speak. So thank you for those comments.
Well, one second, can I add something really quickly?
Yes, yes, please.
The Norman said something that I was just like, it's one of those things that we come in and all of a sudden everyone thinks that like we're these magicians, you know? But it goes back to like he said, like go back to like your basic um the first things you learn probably in the first year or 6 months of your education, not even just your training. But like if someone's blood pressure is low, like what do? You lay them down, right? So if the patient's blood pressure is low, I'm gonna call anesthesia, but while I'm waiting on them, let's drop your head down. Let's bring your feet up. If the baby, who knows, is tracing is looking a little bit funny, run your blood pressure and maybe just throw some oxygen on. Those are things that you can easily reverse, change, move around. But they're really, really simple things that I think people they forget. So we'll just come in the room and throw a nasal cannula on and boop. And we get the standing ovation on the way out the door. You already have what you need. I don't want people to be um handicapped by like waiting for us all the time to come and do something. You have the skill set and the knowledge base to do the things.
Yes, and I just want to say last year, um, Norman did an excellent presentation for AWHONN's Maryland section chapter for our conference on this exact thing that we're talking about today. And it was wonderful. So having that teaching, anesthesiologists and CRNAs, you guys are great teachers, and being able to discuss those principles with the team is very important. So when it comes to patient-centered care, we know that patient-centered care is very important. What does that mean to you, and how do you lead with that initiative of patient-centered care when it comes to anesthesia? Norma, you want to take that one first?
Sure. So patient-centered care, applies to, every single patient in the hospital, but it does not mean that every patient needs the same thing in the hospital. So you have to walk into every single patient's room and like you're meeting them for the first time. And in most situations you are, but um and there's some, foundational things that every patient needs, but um really speaking to the patient, knowing your patient's medical history, um picking up on the body language cues of your patients. uh Not everything is going to be written or in black and white. Some things you'll be able to some needs of the patient you'll be able to gather just from looking at the patient or listening to the patient or hearing conversations that the patient has had and with other people, whether she be on the phone, her disposition towards the nurse. Does she need a more jovial environment, or do you need to go in and really decrease the stimulation in the room, turn the lights out? Is she an anxious patient? Is she an introvert? Is she an extrovert? Does she like hospitals? Does she not really like to take medicine? Is she compliant? Is she not compliant? So there's a bunch of different things that you can assess to kind of get that needs list, if we'll call it that. But as far as the patient setting, I've worked at a number of different facilities, and a lot of times it's centered around family-centered care, and family-centered care is great, right? And I'm all for making sure that, the family is vibing and everybody's happy and everybody's doing great. But in labor and delivery especially, I found that it's more important to make sure that this mother is okay, because she's kind of climaxing in her gestational journey. This is the end of the process. But there can be situations where not all the stimulation that she's getting is positive. Like I've encountered some situations where um husbands, are not very supportive, or uh, female family members, older female family members, scowling at the patient from the corner because she's decided to get an epidural. Like, you don't need an epidural. I've been in situations like that. Um, Situations where, the mother, it's sometimes it's not necessarily a happy time for the mother, um, for a variety of reasons. It could be the relationship with the father. It could be an unexpected or unplanned, pregnancy. A lot of uh, familial sorts of pressure. So it's not just, oh, I'm in here, I'm having a baby, and everything's great. It's, a lot of times it is, but sometimes it's not. So, and this is not exclusive to anesthesia providers. I feel, anesthesia providers, nursing, the OB, we all need to kind of be on one accord with that, so that way, when I show up like in a patient's room who's finally requesting an epidural at 7 to 8 centimeters because her grandmother is no longer in the corner scowling at her. I know I'm better armed now with how to go in and approach the situation and talk to the patient, and and see how it could be the best experience for her.
Dr. Turner, thank you for that. Norma, Dr. Turner, did you add on anything else to that question?
I think that, the patient's needs, like personal needs that she's verbalized, have to be acknowledged. And what is it? We listen, we don't judge. We have patients that have, religious reasons why they refuse blood, or patients that, for whatever reason, with religion or otherwise, they don't want a male provider, or who knows what it is. And so when, it, like Norman was talking about, you have that conversation one-on-one with the nurse. Oftentimes that conversation, that exchange of information is happening right there at the patient's bedside. She's in earshot of everything that you're saying. And we all read between the lines, like, the way somebody said something, and the way their eyebrow went up and stuff like that. So, she's a Jehovah's Witness and she doesn't want any blood. The patient doesn't need to see you judge that. You know, it's like, okay, I'm going to tell you what, if I do have concerns or what have you, about it, but to make her feel bad about this thing that she needs. Patients come in with birth plans and doulas and, all these people. So, respect her autonomy, in that space and in that moment. Um, and if there are concerns that you have, and rebuttals and things like that, like, we're here as a partnership. And so that's what, the discussion has set that tone first, that you and I, patient, nurse, and nurse anesthesiologist and patient anesthesiologist or whatever, we're all here to come to, you know, the final goal of having a happy baby, a healthy baby, and a happy and safe mom. And we're gonna get there some kind of way. We might have some bumps in the road, but I respect this woman and her ability to make decisions for herself.
Thank you.
Oh no, I'm sorry, just to
Mm.
kind of piggyback, to also know, like, patients come in and they have their own list of needs, and Dr. Turner just mentioned the birth plan, and it's always, I don't want to say alarming to us, but it's always interesting to the anesthesia, but I've had women come in with laminated birth plans, like in a binder, like, I want this, oh, hang this above my head, so everybody knows, it's a whole big thing. So, um, and respecting that plan, like, okay, I love that this is your plan and this is what you want. But to be real with the patient and let them know, like, hey, I see you have A, B, and C on your list. You have D, E, and F kind of working against that. So there, we may have to meet somewhere in the middle, because this may not be the best, on the road to the best outcome for you, or you may experience some symptomatology or some other things that you don't want to experience, that you don't necessarily want to experience, because you had this kind of finite list. I went, So where can we compromise? Where can we maybe swap a few things out so that we can make sure that you're healthy, the baby's healthy, and you still have a good experience.
Thank you. The beauty of our patients coming in and having plans, and we definitely are supporters of birth plans, and also at the same time making sure they're talking to the providers and sitting down, and even with their clinical situation that's currently happening, what are some things that we can give autonomy with the patient, as well as having those sometimes tough situations when things are changing or could change acutely because now my clinical status has changed. So, make sure we're uplifting those conversations and bringing the team in for that. As we segue into hemodynamics, we talk about principles of epidural anesthesia. What are some of the hemodynamic principles of epidural anesthesia placement for a laboring patient?
Um, so an epidural, for the folks who are listening who don't know, people just, it's just a needle in the back. Well, it's a way of getting a catheter to a space so that, and a catheter is just basically a tiny straw, right? So we got to get this tiny straw into a space that houses the nerves in your spine that end up going out and kind of feeding and giving sensation to your body. And when we do that, and we kind of numb these nerves or whatever. These nerves not only provide sensation, but they also provide information for your body to work, right? So whether it's your gut or whether it's your blood vessels and things like that. So when you turn off that communication to sensation, it also turns off the communication to information going out. So there's efferent and there's afferent information moving back and forth. When we put those nerves to sleep, we put all of it to sleep. We don't get to pick which nerves or which parts of the nerve we put to sleep. The information going out, the information going in, they both stop. The phone line stops. You can't talk to anybody, nobody can talk to you. So when we do that, we block the nerves or the impulses, the information that tell your blood vessels to squeeze or to relax. And if we go up high enough, if we put the epidural medicine up high enough, we can actually block the nerves that tell your heart to beat faster. Um, so in laboring mother who has this big old uterus and all of this new blood flow going, and there's a baby in there too, that dance is it's not complicated for us because we do it so much now, but it's a complicated dance, right? So if we have a mom who is preeclamptic, preeclampsia causes, kind of this chronic inflammatory thing where you're just basically the mother is fighting her placenta. And with that inflammation, it causes blood pressure issues and all that stuff. So when your blood pressure goes up high, um, your body tries to fix that by getting rid of pressure some kind of way. And the way that it tries to get rid of pressure is it tries to get the fluid out of the blood system, the bloodstream. So preeclamptic moms are usually kind of dry. They're kind of dehydrated, right? Because the blood vessels are always clamped down. And so they're peeing out all this volume because their body is trying to bring their blood pressure back to normal. Well, now I put an epidural in and I stop her from squeezing her blood vessels down. Now they're going to open back up. So imagine you have your your water hose outside and you don't really turn the hose on all the way and the water just kind of drips out the end instead of shooting out. That's what ends up happening. So you just have this kind of drip of blood, as for the illustration, going through the system. Well, that's not going to that couldn't get to the baby. Maybe it doesn't get to the mom's brain. Maybe it doesn't get to her heart, all these other things. So now her blood pressure drops and, all kinds of things can happen with that. So when we put an epidural in, going back to the very, very start of this conversation, I need to know everything that's been happening with this mom. Is she making urine? Does she have an IV? Has she been getting fluid or has she been drinking fluids? Is she taking blood pressure medicine? Did she just take them? Does the mom do any type of drugs that could affect her hemodynamics? And both of us have had moms who come in who have been acutely intoxicated on cocaine. So cocaine makes your blood pressure go up. And now I give her this medication and her blood pressure tanks out. So um like Norman said, the process is the same every time. I need to know this information, and then that's gonna determine how I move. Do I need to give her a fluid bolus? I think that's kind of standard protocol for a lot of places. That you call for the epidural, the nurse opens up the fluids, it gives you a 500 cc bolus. It's because your blood pressure is probably gonna drop, and I'm gonna take away your pain. When you're in pain, you tighten up and you clamp down tight. So your blood pressure goes up. Well, now I take your pain away and your blood pressure. So it just starts to stack, right? So I want to keep mommy safe and thereby keep the baby safe. And so those are the things that we're thinking about with epidurals and hemodynamics is the floor gonna drop out of her blood pressure when I put this epidural. The medicine in the catheter is not the thing that does it. It's the medicine that we put into the catheter.
Thank you. And Norman, I know you have some comments on this one.
Yes, this is always the thing, the most common anesthesia OB discussional type of situation. It's like the hemodynamic state of the patient. Um, before you even get to the epidural or the spinal placement, which Dr. Turner said, they're both going to lower your blood pressure. Um, you have to know the baseline of the patient, right? So a lot of times I'll go in and I'll just kind of glance over at the monitor and I'll see a blood pressure. I'm like, has the patient, is this kind of where she's been living? Her blood pressure's been since she's been here. Has she had any blood pressures that were kind of like outliers? If I walk into a room and your patient has a pressure of 95/60, I need to know if that is new or is that where she lives. And I've been in situations, I've been in both of those situations, and I'm going to approach them a little bit differently. If she lives down there, when I'm coming with the epidural, tray, um, I might be coming with some ephedrine. I'm going to be coming with some phenylephrine. I might be coming with a pressure bag because I really want to get her blood pressure up higher because, like Dr. Turner said, when we take that response away from your sympathetic nervous system to do all that fight or flight stuff, that's called a sympathectomy, right? So if we take your body's ability away to those vessels to squeeze down around your blood volume and create an actual pressure, we take that away, couple that with a patient who's baseline bradycardic. She lives in the 50s. So not only does she have like this, we've taken away that ability, her heart rate doesn't get above 50 in most situations. So the pump is slowing and the squeezing has been taken away. So in both of those scenarios, it could be very, very dangerous. We're, you know, a lot of times when we get called, um, I don't think a lot of that is really taken into account. Like, oh, she just wants an epidural. She wants an epidural. And I've told patients like, we might need to wait a little bit until I get this volume on you. Volume is so super important. I mean, like, it's probably, if I had to put it in the top three, it would definitely be in the top three. Volume status in the OB patient is profound and important. And so I gave that same lecture again. And in that lecture, I threw in there, I added, know the hydration state of the hydration status of your patient. Like Dr. Turner said, has she been drinking or has she just been kind of just laying there? Is this a patient that you're refilling her water every hour? Did she come in with a water bottle? All of that kind of plays, because what you don't want to have happen is you come in, put an epidural in, we get that hypotension, right? The blood that gets delivered to the baby drops, and they're in like this profound, and we've all been in them where you see that decel on the screen and you're like, like in the movies when they zoom out and pan in at the same time, it's like, oh my God. Like, so, and then you're repositioning the mother, giving all, IM ephedrine, IV pressors, when you don't really have to go down that road. And I will, the importance of counseling your patient, I think, is super important. It's like, hey, I'm not making you wait for this epidural because I'm being a meanie and I want to see you in pain. No, I'm waiting for this pressure bag to squeeze this whole liter in you, and it's only going to take like maybe 3 to 5 minutes. But this liter bag of fluid is going to put you so far ahead than you are right now. If I put this epidural in you now, you're running a risk of a whole situation happening. So I think um, having those discussions with the patient, and even with nursing can have, that discussion with their patients before they even call us. Like, hey, your blood pressure's a little low. Anesthesia is probably going to have a little bit of a concern. Um, I want you to start drinking for me. Can you have a couple glasses of water, or call anesthesia. Hey, anesthesia, she's thinking about an epidural. I'm going to put this on a pressure bag. Are you okay? How much of this fluid do you want? This is her medical history. Um, to keep them informed about the entire process and to let them know, you know, how important the hemodynamic situation is with regard to not only the mother, because when her blood pressure drops, she's going to feel icky, right? She's going to feel nauseous. She's probably going to start puking all over the place. And we don't want you going through that. And when your blood pressure goes down, baby's blood pressure goes down, and he ain't going to be feeling the greatest either. He's going to be throwing D cells at you left and right. So when you think about it, like, oh, what takes care of that fluid? It's a simple thing. Fluid, fluid is your friend.
What easy thing that people can do, and this is for lay people or anybody else, is if you have a blood pressure cuff at home, one of those automated blood pressure cuffs at home, when you say you get up in the morning or you're laying on the couch, right? You're flat. Take your blood pressure, right? And then stand up, give yourself, 30, 60 seconds, and take your blood pressure again. Your blood pressure will it goes up because now your body has to fight gravity to get blood from your feet up to your heart. Well, imagine if that didn't happen. And we've all, especially some of the older folks, you stand up too fast or you lean over to like tie your shoe or get something in a low cabinet in the kitchen and you stand up and you're like, whoa, you feel a little you feel a little queasy, like Norman just said. That's your blood pressure didn't catch up in time and now your brain feels it. And so, God made us in these wonderful ways where we get all these signals before bad things happen. So that nausea is just a signal that your brain is not happy. Or, that chest pressure or whatever. And that's kind of a deep one. That's your heart muscle is not happy. So, a mom saying, and that's the first thing that I usually ask, do you feel nauseous? Because the blood pressure might go down a little bit. The baby looks okay, but the nurse is like, but well, her blood pressure is this. And I'll ask mom, do you feel nauseous? Do you feel dizzy? Do you feel odd or different? And if mom can tolerate that blood pressure and the baby looks okay, then I don't have to, because what I don't want to do is treat numbers. Um, and that's what I tell my residents all the time. You'll start chasing those numbers, but what those numbers signify something. So I can make that blood pressure look like any number I want it to look like. But if it doesn't need to be that way, um, you might be making yourself feel better. And if there's any question about the decision that you've made, again, going back to a previous part of the conversation, document it. You've made a decision that might look a little funny to someone else. I talked to the patient, no nausea reported, you know, fetal variability or heart racing variability is appropriate. We're going to hold here and I'll check her out in 30 minutes or an hour.
I'm glad you mentioned that because sometimes the blood pressure is low and the mom may be feeling okay, but the baby's not doing well. And we may see that simultaneously, and then sometimes we'll see a delay. So making sure again that the provider's at the bedside, we're having a conversation and talking about the plan and even looking at trends. Look at the trends. We have to look at the trends of blood pressures and if they're going up or are they sustaining going down. So that is very important. Um, so hemorrhage, this is a topic that is hot. Hot topic. And one of my favorite topics. But when it comes to obstetrical hemorrhage, we are seeing and continue to see a rise here in the United States with patients who tend to have more bleeding. And there's a lot of factors that contribute to that, not just one thing. So when it comes to factors related to hemorrhages. What are the important key factors in the eyes of anesthesia when someone who has had a vaginal delivery or C-section that you feel most important you want to amplify in this discussion?
IV access. IV access. I can I can do a lot of things if I have an airway and an IV. So, I think there's and it maybe it's just the way that I grew up in anesthesia, but every laboring mom, whether it's a preemie gravid or, someone who's had 8 C-sections, the minimum size, gauge for the IV is an 18. Um, and one of the things I do with my brand new resident is I say, look at the packaging of that angiocath. It tells you the flow rate on there. And going from a 20 to an 18 goes from like, I don't know, is it like 102 or something for a 20 to like, I don't know, maybe 280 cc's per minute for an 18. It's something dramatic, right? Like, so changing the radius of that catheter. So give me a big IV and then type in screen. Then we can go. She's, I can do a NTE or something like that. Um, as long as I have an IV and I know she doesn't have any terrible antibodies, I can probably keep her alive.
Absolutely. I 100% echo that. Um, I joke with the places that I go that use 20 gauge IVs, and don't get me wrong, sometimes patients come and that's, all you can get, but that seemed like very entry level with most places. Like I think they just kind of like pop this 20 gauge in. It's like, but and this goes back to knowing the patient's entire history, right? Not just how they're presenting to you today. So for example, is she before this and knowing them before this hemorrhage even takes place, right? So was she chronically anemic before she started to hemorrhage? Like where are you hemorrhaging from? Are you hemorrhaging from the top of Mount Olympus, or are you hemorrhaging from the roof of somebody's garage? You know what I mean? It's vastly different, and she's going to present to you differently in both of those situations. So yes, it makes me nauseous to see a 20 gauge anywhere on a labor and delivery unit, to be quite honest with you. Um, I'm a staunch advocate of the 18 gauge in labor and delivery being the entry level angiocath, but that's a whole different conversation. Um, and then not only that, how many C-sections has she had prior to this? She may need more than one of those bad boys. You know what I mean? Like she might need two 18 gauge IVs. Um, has she had a transfusion before? Did she have a reaction before? Does she have antibodies? We see a fair amount of patients who come in and do need special antibody ready blood that will match the antibody, that they have. Um, is she a patient that's going to accept blood? Like Dr. Turner was talking about earlier, we have patients who like, I don't want blood, even if I'm dying. And, those are always the patients where it's like, ooh, it's hard. So what are you gonna do? Like, will you accept albumin? It's a byproduct of blood. Will you accept that? Will you accept, head starch and all these other, colloidal sorts of fluids that we can get?
Do they have head starch anymore? I don't think they make head starch anymore.
Don't make them anymore.
Well, because all the data came out was fraudulent information that he used. Yeah.
I haven't seen, there's one place that I know that still
Oh.
had it, but I don't see it. I don't think I've
The
ever
expiration date.
Right. I don't think I've ever seen it given, but when you're in a tight situation and you got a Jehovah's Witness glaring at you, like what's that you hanging? You know what I mean? You have to know exactly everything you can and cannot use for a patient. Um, knowing beforehand, set yourself up for success as the provider. I always, I plan for, we anesthesia provider, we plan for Armageddon, you know, and most times it's not, but you've planned for it, right? So you're more comfortable going into that situation. That's not exclusive to, the anesthesia discipline. Nursing can do that as well. Like, oh my God, I got this chronically anemic patient on like these iron transfusions that she didn't really respond to, and she hemorrhaged with her first pregnancy. Da 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 da. Well, before anesthesia gets there, go to make sure that she has an active typing screen, a typing cross in there. Most places say, the type and screen is only valid within this amount of time. So as the nurse caring for the patient, do I have a valid one? Do I need to draw another one? Does anesthesia know that this patient's here and she's chronically anemic? Does anesthesia know she hemorrhaged before with all of her pregnancies? Does anesthesia know that she has this crazy antibody? Does anesthesia know that she's advanced maternal age and this is a multiple gestation, and all of the things that were predisposed the patient for a uterine hemorrhage, right? Just go through the list. And as the anesthesia provider, for us, that IV is not only that she has a large bore IV, but that it's a functioning IV, right? Because people will look at like, oh, she has an 18 gauge, and they'll whisk the patient off for a C-section, and then we get it, and it's like, like, no, I'm not infusing. It's like, man. So all the little things, so, sometimes, in the heat of the moment, we can kind of overlook the very simple things and kind of overthink things. But like, what's going to help this patient if she starts to bleed? And it's very simple: IV fluids, and that I have blood ready, and that I've communicated it to the team that like everyone knows that she's high risk for hemorrhage. But if you're starting off from there, you're starting off from a good place.
And the last thing I add about the IV thing for the larger patients, the ACs are terrible places to put IVs, because their arm can hide. So if the IV is infiltrated, their forearm can hide a lot of fluid before we know that the IV isn't working. So if you have a larger lady and the only vein you can find is her AC, I beckon you to probably call your anesthesiologist and ask them if either do they have longer angiocaths, so we have longer catheters, or we have these we're called the rapid infusion catheters. They're kind of a little bigger and a little bit longer, and have the anesthesia provider put that IV in, because that we have a lot of really big folks, and that adipose tissue will wiggle that IV out if it's not in the right place.
In this discussion on obstetrical hemorrhage and response systems, definitely gonna be its own podcast. One of the biggest things that CMQCC came out recently is 40% of patients that come in with an obstetrical hemorrhage do not have risk factors. So what I hear what you saying, making sure that we have good IV placement, that we have good response system algorithms, as well as pre-briefing, discussing these things. Some of these things are happening prenatally that are causing or possibly increasing the risk factors of bleeding, or it is something that is happening in the intrapartum. We take care of patients acutely, so making sure that we're reviewing everything in the hemorrhage cart and doing simulation training, as well as having conversations, having the blood on the unit in the OR if they are having. We're starting off with a low threshold of a 6.5 and 28, or do we need a transfusion before the C-section for that obstetrical patient? So these are great things that we have discussed.
Oh, wow. This was a really great discussion, Dr. Turner and Norman and Lakeisha. I hope everyone listening was catching all of the drop nuggets. I tried to catch several of them myself. The wrap up of what I heard is that your anesthesia provider's number one concern is the patient's safety. They're navigating multiple factors with the patient's health and with their relationships among other anesthesia providers, the OB, and nurses to center the patient's care. And I also heard you all talk so much about information and awareness about the environment on your shifts, and the early, clear communication. Those are paramount, especially in the emergency situations. So take time outside of those emergencies and get to know your anesthesia providers and ask questions. It sounds like they love to educate. Norman, I really love the laminated birth plan example that you shared, because as a childbirth educator, I believe it's my responsibility to inform expectant parents long before they get to the hospital that if they do want A, B, and C, that they should also be ready for D, E, and F. And so they need to remain flexible and they need to stay hydrated. So for all our listeners, visit us at awhon.org/podcast. You can read Dr. Turner and Norman's bios there. You can utilize the resources they shared today. You can also watch on YouTube. You can re-listen on our streaming platforms. Please recommend this episode to a friend. You can write us at podcast@awhon.org to send us a comment about your listening experience. We appreciate your time so much today. Thank you all. Thank you to our guests and to you, Lakisa. And everyone, stay well and be safe.